We're going now to present our second presenter, Dr. Amr Mohammed, who I have the honor to work with him maybe for 2 years in Galway University Hospital. Dr. Amr is working now as a fellowship, as fellow of ICU in Mater Hospital. He has a very long experience in ICU and anesthesia, and I attended a lot of his presentation before in Galway, which all of us enjoyed it. So, Amr, yeah, you have the floor now, and you can go on.
Thank you. First of all, thank you so much, Dr. Mahdi, for inviting me to be with you today. It is my pleasure and my honor. And thank you so much, Dr. Mohammed Hassan, for the nice introduction. Today, my presentation is about breaking bad news, and I'm currently working in Mater Hospital as ICU fellow. So it is another day about communication in the Mega Association Academy, and we are all of us know how important is communication. And communication, it is not something which happened by a chance, but required a systematic and considered approach, which need to be improved over time. And because it requires training, it has been cited as a reason for an anxiety between the trainees and new consultant when they are in this situation, when they are breaking a bad news to the families about their beloved ones. So first of all, we need to know what are the bad news. So the bad news is any news that can affect the patient or their family view regarding their future. And this effect will include cognitive effect, behavioral, emotional effect, and that will be not only during the time of delivery of the information, but this will be persistent for a longer time. And that's really very important to understand and keep in your mind all the time. Those moments will not be forgotten in their lives forever. And that's really very critical and sensitive situation. And our task, we try to make it less harmful and pleasant as much as possible. And the bad news, as you know, it will affect the patient according to their expectation, according to what they know about their beloved one, what they expect. And at the same time, it will make the future less scary to them. So they want to know this information because it will help them to plan their future. But at the same time, it is really very traumatic news. So it is very important to be clear with the patient, open with the patient, catch them in the right time, get them ready and prepared. And at the same time, there is no pressure for the family members or the family themselves to make any decision in a hurry. They are involved in the care, but they are not making the decision. And that's another important fact we need to keep in our mind all the time. And we need to disclose this information very clearly to the patients themselves or their family members. So that is a complete medical decision, but they share in the decision as well, and they share in the knowledge. So that's really very important, and they really appreciate getting them involved in board as early all the time. So it depends. It is different from one family to another. It depends on their ability, how they can deal with a stressful situation, and it is really complicated topic because it depends on the social part of the human being, which is really complicated as we know. So it depends on the expectation of the patient or the family members. It depends on their previous experience if they had already same situation with other a loved one of their families. It depends on their social and personal depositions, what they believe. The culture is very important. I'm going to give you a good, clear guide on how to deliver this information, but you need to test your culture. You need to know your community. What applicable here in Ireland could be not applicable in Egypt. So it is important to speak to the people according to their culture and their beliefs. It is also the difference in the negative feedback is different from one to another, and the emotional response is different as we know. And there had been many studies that refer to multiple reactions from the family. This could be just me just saying simple as frightened or or scared, or it could be we could have one of the family member or the patient himself shocked or having a severe depression or having a bad reaction or suicide attempt afterwards. That's why it is really very, very important to deliver the information in the right way, in the nice way as possible, and to make it less harmful and to choose the right time. So this data is from the state, which shows that nearly 22 deaths happen in the ICU. But when they surveyed the family members of the related to the patient who died in ICU, they were surprised that 54% of the family members, they don't have a clear understanding of the diagnosis or the treatment or the prognosis. Imagine if this happened in the state which we think that the level of care should be good enough. So what about other places? So that's really very, very important topic to discuss. And that's why all of us here, I know it is a weekend and evening time, but I know you are interested in the patient care. I know most of you had already good communication skills, or maybe you are teaching these skills in courses. So it is really very important topic, and all of us as a clinician in different specialty are involved in breaking bad news to the family members about their beloved one. And also it is very stressful and very difficult time, and we try to keep trust, we try to keep a good relationship, we need to maintain a positive experience about the hospital even if the patient or the beloved one of the family has died. We still need to keep them having a positive and clear, honest relation all the time. So it is really difficult situation for everyone involved in those situations. But I can't beat you. Every physician will have this position. So you need to get yourself ready and prepared. The problem is that patient themselves or their family members, they believe in, they are hoping all the time and they believe in miracles. And we as a physician believe in miracles as well. But we need to be realistic all the time. It has been said before that intensivists are analytic, but what we are saying to the patient, we tell them we hope for the best, we remain optimistic, but we can't ignore that the worst can happen. So plan to the worst while hoping for the best all the time. That's the bottom line. And we need to be realistic to our patients and to their family member all the time. We hope that the patient can improve, they can make a progress, but we need to rely our information based on the best available evidence. So that's really very, very important. And also it is important to know the family members. So the communication with the family, it is important to be done by the colleague who had already involved with them before, because they know the family member very well. If there is any discord between the family members, if there is any conflict, if there is any mixed messages, it could be removed by having one colleague talking to the same family all the time. But this is not practical in main situation because of the rosters and working hours, but that's the best. If it could be done, it will be really great. And it is important to keep in mind that some of the family member will be religious, so it is very important to keep talking to the people at their level from their point of view. So that's why it is a difficult situation. It is a challenging situation. Everyone in this has been in this situation, know exactly how it is challenging. And the problem is specifically in ICU, we could have a patient admitted from the ward, they deteriorated very quickly, and we don't have a long time of contact between the patients themselves or between the family members. And now we have to break the bad news. So we don't have a long-standing relation, which makes the situation really very difficult for intensive care physician. And also there could be situation where is a discontinuity in the care, or there is patient handoffs on regular basis. Also, as there is, we don't know the family members, we don't know the patient relatives, how they will react to the bad news at this time. So that's really another, it will be a surprise for us during this short time while we don't know the family. So the delivering bad news had been stressful to everyone involved in the situation, including the physicians or the family members all the time. And that's why we are here to have a bit of training and teaching and practice. And I'm sure we will have some information which we can apply in our working centers. So that had been already challenging in many situations, especially when you have a patient who had been looked after by his or her close family members, and then one of the family member traveling abroad, and then they came back to see their loved one, which is they haven't seen for years and years. So they lose contact with the family member, with our patient. They don't have how they deteriorate over time, how their medical condition, and now they came back because they are in ICU. And now they want to be involved in the care of this patient and they want to make the decision. So in this situation as intensivists, it is really very difficult at the time. But what we are saying, have you been involved in the care of your loved one in the last couple of years? Do you know exactly how is their medical condition? Do you think if they are here with us and they are listening to this conversation, what's their plan, what they are hoping for? Have you speak to the other family members? So that's the way to get them engaged in this conversation in the right way, because we try our best as physician to care in the very best way to our patient and also to our family all the time. We are dedicated to both in the time, all the time, and that's why the intensive care physician is really distracted between different aspects of care. So the aim of this breaking bad news is need to be clear in our mind. We need to make this time successful as possible and less stressful for the family members as possible. We need to make the discussion of any palliative care. Some people use withdrawal of care, which is not right. It is not withdrawal of care, it is palliative care. So in ICU care, we try to optimize our patient. We try to give them the best available treatment based on the best available evidence. But in the same time, when we see that futile, we see that cause harm, we need to plan for a good this. So this good discussion about the palliative care will not happen if we don't have a clear, good communication during breaking the bad news. So that's really very important. And also, as a human being, it is a dual challenge communication all the time. We speak to the heart and the brain of our family members all the time. And if they are overwhelmed with sensations, they can't really understand, they can't absorb, they can't share in the decision. So the cognitive will be impaired by their sensation. So we need to be empathic with them all the time. When we are involved in the patient care, we need to be more practical. But when we are involved in this communication with the family members, we have the freedom at the time to release our intention, to release what we're feeling and what we're trying to keep inside. During this time, we can release it and we can feel the family. The family has to feel there is a warm heart from our sides when we are discussing or breaking this bad news during this very stressful time. And really, that's very important to keep the trust of the family and to keep them main aiming for having the best treatment during this time. So the time that management is tailored according to the time in our patient care. So communication as an issue in every place, I believe, and it could be improved every time. If it is not, if there is no clear problem, it is an area which easy could be improved by time, and that had been already well studied in different literatures, in different articles, trying to have a practical approach and how can we improve our patient and how is the communication skills can be taught. Of course it could be taught. That's why all of us were here today, to learn more and to take some new tricks or new tips and to try to apply it. It's a matter of practice. We are not born a good communicator, but we can learn and we can grow it up with time and we can practice. We can have simulation and we can have courses and we can improve ourselves with time, of course. So there had been many studies, of course, teaching the other practical skills as intubation or central line is much more easier, but still communication, one of those skills which can be taught and can be improved over time. So this review of 1,500 separate randomized controlled trials that happen in oncology patients where most of palliative care decision is going to happen. And they found that communication skills training programs improved the clinician skills, and also it didn't affect the patient outcome, but it improved the patient family satisfaction, which is really important. And that's another Cochrane review of 43 randomized controlled trials, which examining the communication intervention studies in a variety of clinical sites. And it showed that the patient-based outcome is better in terms of patient satisfaction and patient mental health after that traumatic events. And also another systematic review of 11 randomized controlled trials and showed the same, that if that communication could be improved by having simulation and training courses, and it leads to improvement in the patient satisfaction. So if we have a patient who is already very sick, is not making any progress, we feel the patient is going to die. How is the best approach to speak to the family and to try to having this time in less stressful, less harmful to the family member? And that's a problem in ICU. Most of the patient in ICU don't have the capacity, and we have to speak to the family member, and we need to have a clear checklist beforehand in order to conduct this discussion in the best way. So first of all, we need to prepare ourselves. Just we need to have a few minutes beforehand. The preparation is the key success in any project. Try to have our thoughts organized, our goals organized, our agenda. Which family member actually we need to be involved? As we know, all of us, it is the next of kin. And from country to another, it is different. You can have a family which is very big family, and all of the family member want to attend the chat or the discussion about their loved ones. They have the rights, they want to know, but it has been well advised that we need to speak to the next of kin, plus one or two maximum. So the other ones will support the next of kin because it is really difficult news, difficult situation. But I advise my colleagues, don't have a discussion with more than three of the family member at a time. Ideally, it is two, but maximum of three. That's my advice to you, because it is usually the next of kin can deliver the information to the rest of the family member, and that's the best way to have less conflict and the best way to have a clear message during this difficult time. So when you meet the people, you need to have your agenda ready in ahead. So you need to know them, ask them by their name. First of all, you need to introduce yourself. And it has been a big campaign in the Twitter, Facebook about one of the oncology physician in UK had been a patient with a tumor and was surprised that plenty of doctors coming to the room every day. No one of them introduced themselves properly. They expect they are well-known figures or artist or singer, which is not right. So we need to introduce ourselves to the patient or the patient family members. And the way we do it, introduce, is your first family name and your role and the hospital you are working, because you could be just a consult from a different hospital. So that's the way you introduce yourself. And you ask the family members about their names, and that's very important key communication during this difficult time. You speak to them by their names, you speak to them in their eyes. I can't see all of the audience now. Sorry, I can't keep eye contact with you, but it's really very important to keep people engaging all the time, and also to keep people feeling that we spend a good time with them. And also, we need to speak to our colleagues. It's very important to have the nursing staff colleagues involved. And if you have another, some meetings could be have both registrar and the consultant in the same time. Feel free to ask support and advice from your colleagues. They are we have a great colleagues all the time willing to help and support. And of course, all the training, I used to ask my consultant if there is a chance for me to attend, to join you for the meeting, to learn for my own practice. The location is very important. We need to keep the privacy, dignity of the patient, family members all the time. We need to make sure it is private. We need to make sure that it is having a nice number of chairs for our patient. We have plenty of tissues, plenty of glasses of water, and the layout should be fine. It is not a party room. We are speaking breaking a bad news here, so it should be a suitable room for discussing such stressful news to our family members. And also, we need to be completely engaged with them. So turn off your phone, give your pager to another colleague, take your time. It is important to spend decent time, sufficient time, to make the family satisfied, understand all the questions has been answered, and they don't feel that you are distracted, you are under pressure, you just came and you want to leave quickly. So that's really important. And one study in the ICU has been demonstrated very clearly. If the clinician is far away from the patient bedside, standing away, and just looking at the patient chart or the computer screen, you don't feel how much time exactly the physician stayed in the room. But when the clinician or the intensivist have a chair sitting beside the patient, trying to make them feel they're around, trying to speak to the patient, chatting with the patient estimate over time. If you stayed 1 minute sitting in the chair beside the patient experience it as 5 minutes. And that's the same situation for the family. And of course, we need to support our family members all the time. If there is a social worker service in the hospital, that's great to take them on board all the time, keep them with you. So you start with introduction. I said how you introduce yourself, your name, your role, your hospital, introduce other staff member, our nursing colleagues, if there is anyone from the social workers, if there is any intensivist or physician from primary team or from different specialties there. And also ask the family member to introduce themselves as their name and their relation to their loved one. So you know exactly their relation. And then you need to start by asking them what the family they know about their beloved one. So in order to avoid giving mixing messages, in order to understand, have a sense how is the family member. It is a human being conversation like any other one. You need to understand the people you are speaking to them in order to speak to them in the right way, in order to speak to them in the way they can understand, in order to have an idea what they can deal with, in order to expect what will be their reaction. So that's very important to ask them. And also give them a warning that I am going to give you a bad news. Don't just throw a bad news at the times. It can cause a heart attack to some of the patients which are elderly and sick with other problems. So you need to warn them. You need to have their permission and agreement, and you need to get them ready that you are going to give them a bad news now. And then you should have already all the information in your mind about the patient. So you should have reviewed the patient chart. You should ideally have been involved in the patient care at some time, or at least you know the patient very well. And then you are going to speak to them in very clear language. There is no jargon. Speak to people in the language they can understand. And keep in mind, if you are in English speaking countries, there are different accents. So keep in mind you speak clear, simple language, simple as your listeners can understand and can react. And you need to see the reaction in your face to make sure that they understand what you are telling to them. Deliver the information in a small bites. So don't give more than 3 facts at a time, because our human being brain needs time to process the information. So I would say, for example, Michael is very, very sick, very critical. He is connected to many infusions. He is taking powerful antibiotic, but he is not responding. So gives a family member 3 facts maximum at the same time, and gives him time to understand, gives him time to process the information. And the most important thing is to tailor the information according to the family members' level of education, level of understanding, level of knowledge. And the most important during this time is also to try to give them the right amount of the information, which is a difficult balance. It is different from one family to another. Give them a chance to ask you for more information. Give them the basic information first and then wait. So the silence is your friend. The most important part of this discussion is to keep silent for some time. Few seconds make a big difference. Few even minute make a big difference so they can understand. And you need to allow them to ask and allow them to reflect, and you need to check their reflection to make sure that they are understanding what you are saying to them. And silence is really very important during this time. When you listen to them, use active listening. So engage by your eyes, by your position. Make sure that you show them you are actively listening to what you are saying. Allow a decent time for discussion if they have a query, if they want to understand, if more concerns clear or clarification has to be asked. That's fine. Give them the time. Don't hide your emotion during this time. This is the only time for us in ICU we can safely express our emotion. We really feel upset and sad as well about our patient, that there are no way to fix their problem, no way to get them in the right direction again. Make sure that they are understanding. So ask the patient family members very clearly, do you understand what I'm saying to you? Or in your own word, what can you summarize, please, what I have said to you? Can I ask you, please, when you go home to your loved one, what you are going to tell them about Michael? And also speak to about don't say the patient. I will go through this in the next slides also. Don't speak about the patient as they are not present. Speak about the patient as they are in the room, as they are involved in this conversation. The whole point is that the family member have the capacity and we are asking them, and the intention is to know from them what is the patient's value and preferences. So medical team, ICU team are expert in delivering the medical care, but the family members are expert in the patient preference or patient values. Give them time to ask for any concerns. Have open disclosure all the time, and you need to end by summarize the facts, because a human being, they tend to forget. That's the nature of all human beings. Summarize and emphasize what you want to say. Ask and answer all the questions, and then you need to close the meeting after that. And when you go to back, you need to write. You need also to support the family all the time, and after ending the meeting, offer to them a follow-up, and you need to write your documentation in the clinical notes about how this went on. And also it is an area of improvement, so you can ask your colleagues about their feedback. And later on, if you catch a good time later on, you can ask the family members about your feedback, because measurement of the outcome is the only way you can use to improve yourself. So planning is very important. We need a quiet place, quiet room. We need a dedicated quiet time for the patient. We need to know all the information before going to speak about the patient to our family members. So we need to have all the information, all the results, or if there is any imaging, if there is any specific important blood test, what treatment options has offered so far, and what's the outcome, and what's the next plan we are going to offer to our patient. Uh, when you discuss, usually when physicians speak to the family members directly, the patient directly, the patient themselves, in most of the studies, they want the physician to make the decision themselves for the patient best interest. But the problem here in the ICU, because the patient don't have the capacity, we speak to the family members, they are overstressed, they are under pressure, they don't know that they don't have to make the decision. They think they have to make the decision, and they want themselves in this situation. So the family members want to make the decision on behalf of the patient. But actually, what we want to know from this meeting, we want to know the patients themselves values and preference, if they have expressed advanced direction of their wishes, or if it has been discussed, or from their character, what they think their beloved one will behave, or what would you like. It is important also to have a conversation with different consultants from different team looking after the patient to have a complete full picture agreed by everyone involved in our patient care. And sometimes, as we know, we use the language as a tool of communication between ourselves. If we need interpreter, it should be different, not from the medical team for legal aspects, and should be medical interpreter. And it is, I'm sure, it's available in different hospitals. So the families, in this time of discussion, they thought that if they have enough time to speak during this discussion, they are more satisfied. It is not a tutorial. We're not giving a tutorial to our patient. We need to give a space to our patient if they have the capacity or the family member to speak themselves, to express and to say their concerns. And then we start to answer their query after that. Also, the time is important. It is important to sit down with them. It is important to make them feel we are here just for you and to speak to you about your loved one. So it is really very important to make them feel warm feelings from our sides during this time. And also it is important that spend time, longer time as much as you can to answer all the questions, and that will help to improve the satisfaction, and that will help to decrease the post-traumatic stress disorder. Now they have a bad news about their beloved one, but we don't want to push them to have a post-traumatic stress disorder from ourselves. So rule number one in medicine is not to cause any harm, and that's really very important. Okay, so we have learned that we try to contact the patient directly, face to face, but now because of the COVID and different situation, it is almost over the phone. So we have to contact over the phone, and we need to have a clear approach how to contact our family members of their loved ones, our patient in the phone. So a nice approach is, first of all, this meeting, you don't see the family member you are talking to. So try to have a good preparation. Rehearsing is really very important with your colleagues. What exactly you are going to tell them, what's the aim of this call, and also make sure that usually we try to make the phone call or update the family in the right time as soon as possible. But for this call, try to make sure you have a decent preparation time. You don't need long time, it is just few minutes. And if you chat with your nursing colleagues, with your intensive care colleagues, to make clearly the goals of the calls, what I'm going to ask for, what I'm going to deliver, and what the questions expected from the family member. When you call anyone, you need to check their identity. They are the next of kin. You make to check the identity of the patient. Make sure you are speaking to the right family about the right patient. Don't disclose the information to a wrong person. So the dignity of the patient is really very important. And you need to introduce yourself the same way, your name, your role, and your hospital. Make sure you are speaking to the family member in the right time. They are not driving, so they make accident because you are giving them a bad news. Make sure they have a quite calm environment around them so they can understand. Make sure, if you can, they have someone also in the home to look after them, because you are going to give them a bad news. You need to make sure they are protected and supported all the time as much as you can. And don't be afraid to use the D word. If you think the patient is going to die, tell them, I wish that Michael can improve. I'm doing my best. I'm giving him the best available treatment according to the best available evidence, but I'm afraid I feel that Michael may die. So be clear and open to them all the time. Offer support, make sure that someone will look after them, offer a follow-up call, offer a call from social worker. So that's really important. So that's if you are going to have a phone call about the patient conditions. Okay, there had been many other protocols to help you to organize your thoughts, and when you are going to break a bad news and have organized approach. So there is a speak approach, so setup of the interview in the same terms, and also perception. So make sure that you are speaking to the patient who has the capacity, or the family member who has the capacity, because we want to give them the right information in the right time in order to improve their understanding. But if you find that the family members, they don't really perceive the information the right way, probably you are causing more harm, and we should stop at that point and try to think around, step back, and find another solution. Also, we need to make sure that we have an invitation from the family member, from the patient themselves, that we are going to speak to you about your critical situation. We're giving them a warning that we are going to disclose to you a private information which could be harmful. We need to know exactly what they know initially from another colleague. It could be from the ED department, for example. It could be from the medical ward, for example, surgical ward, surgeons. So we need to know exactly what information they have, and it is a good test to their knowledge and their reaction to the knowledge when they are talking to you. So you can expect their reaction when you will tell them more bad reactions. Emotions, as a human being, we can't separate emotions. Make sure that they are not overwhelmed so they can't understand. Make sure that you express your emotion. We are all human beings, and it is a difficult situation when we are losing a human being life, so we can express our emotions in that time. Try to summarize at the end, try to have a clear strategy of plan and the options, and emphasize what they have agreed, what we have agreed from this meeting. Another approach, ABCD approach. So again, it is about preparation, having built a therapeutic environment or relationship with the patient themselves, if they are capable, or their family members. Clear communication. I'm speaking in the same language, in very clear language that they can understand. I'm speaking about the medical terms, so avoid any jargon, no medical terms. Express as simple as you can. For example, I would say artificial mechanical ventilation, breathing pipe. That's examples to avoid the jargons. And also deal with the family reaction. You can't ignore their family reaction. You can't ignore their emotions. You can't keep hiding your emotion as well. You can express your emotion. And if you can't see any emotion, some people don't they're trying to hide their emotions. They don't believe in expressing their emotion to someone else outside the family member, which is not good. Like, I feel this reaction is going inside themselves, which can lead to something bad. So try even to stimulate them. I know this is stressful situation. I know that's very sad news. Sorry, I'm giving you very sad news. If I'm in your situation, I will be very, very sad and very disappointed. So another approach is to know background and rapport, have a good rapport with the patient family, good chat, explore their understanding about their loved one, about their wishes, about their medical condition. Announce exactly what's the information you want to say in a very kind way, and also try to summarize. So that breaks approach, just another one. And also there is a guide approach. So get ready and understand the condition of their patient, of our patient, their loved one, understand the condition of family members, inform them very clearly the relevant information, go deep with them, understand their sympathy and their emotions, and then make the next plan of treatment very clearly to them. And also there is the serious illness conversation guide. It is really a very nice checklist you can follow as well. So it's the same, but just it is in different organized ways. Set up the conversation the same way, and then try to understand. So the whole point of having this meeting is regarding Michael, and I want to know what his wishes, what his values, what he wants for himself at that stage. From the medical point of view, from the ICU point of view, we believe our treatment is now futile, and we think that the good this is important. Do you think Michael, if he's here sitting with us in the room, what he believes, what he thinks, what he wants for himself? And then you need to share them the prognosis very clear to the best available evidence. There is no way that Michael is going to get out of the intensive care. There is no way Michael is going to improve or respond to any different treatment modalities. We're giving the best treatment to his condition, and he has been in ICU for so and so, and it seems there is no response to the ongoing medical treatment, and we need to make a decision now, and we need to act in the favor of Michael wishes. Express your emotion, silence is your friend. Also explain your from the start the goals of this meeting, summarize all the time, make sure that you know the family members, make the recommendation and make it very clear. And at the end, documentation is very important. If you didn't document this conversation, it hasn't been done. So it need to be important. And during documentation, my advice to you all, if you have some patient in this shock stage, denial stage, mention clearly they denied the information I gave to them. So they probably, what will happen in most situations, there is a shock stage when the family hear for the first time the bad news. So they deny they know about the liver failure. They deny they know that the lung doesn't work in the right direction. They don't know that they deny that they know that the heart is failing. But that's fine. You don't go against what they are saying. You agree to them, but you document and you clear communicate with your colleagues, and then this will be a second discussion. Okay, we can have another difficult situation if we are looking after a family member who are having intellectual disability. So the family member or the next of kin having intellectual disability, so who we don't have a clear next of kin, we don't have really have a family member we can disclose information with. So it is really difficult, could be challenging. So we have at the situation, we may prevent their distress because they won't really able to understand. They won't be able to communicate. They won't be able to make the right decision. We don't have as a clinician the sense that that's the right time for them. It could be conflicting for them having those news. It could be there is no really way to deliver this news to those people. So it could be a serious news to them, and our main intention is to deliver the right amount of information in the right time, in the right people, and help them to cope with their progress or their difficult situation of their loved one in order to progress forward, in order to have a clear idea about the future and organize their plan for the future. That's the first target. So that's a very nice algorithm from up to date. So if the patient does have the capacity, well and good. We discuss the information, open disclosure with the patients themselves all the time. If the patient doesn't have the capacity, and that's the situation all ICU patients, then we have to go to the family, and then we look to the family. Do they disclosure of the information, is it harmful? Do you think the family members they are escaping? Do you think they are negative, they denying, they don't want to know the information, or the other way around? So if you think that they want to know, then they disclose the information to them very clearly. But if you think that they don't want to know, they denying, they escaping, they change the subject, then look at the other way around. Could non-disclosure be harmful? If it is not, so don't disclose. But again, reassess this regularly and discuss it with a senior colleague. But if you think, no, it is not harmful, so then disclose with them the bad news. Emotion is part of this, so they are telling to you, am we going? Is he going to die? He or she? So that's family. That's emotions is coming here, and if they are overwhelmed, they can't really understand, and that's expected to hear, and that's very important. And if you hear the emotions, that's a normal reaction, and you need to admit and acknowledge that. But if you didn't hear it, that make me worry if the situation, the family member did not express their wishes. So what you want to do now, you want to acknowledge the emotion and ask them, are you happy to go ahead and speak about the next step?
The value of looking at emotions as data is that you don't have to change the data. We're not asking you as a physician to fix people, even though the temptation is just kind of irresistible when, as somebody who's here to help people, you see someone in pain and you want to make it better. But the reality is that the way to deal with emotions is not to fix them. You have to treat them with respect. And that is the kind of acknowledgement and validation and empathic skill that we've been illustrating here.
So one of the very nice approaches is the nurse approach. So you need just to nominate the emotions and then understand it, respect, offer support, and then explore further emotions. Some family member could have emotions that they are part of the deterioration of their loved one. So we need to really clarify their concern, make it that clear that could be just the nature of the disease. There's another algorithm here. It's pairs approach, but probably I feel I will be behind the time. So it is very clearly the same values as a nurse approach. Avoid to say patient. Mention the name of your patient very clearly. Avoid to say he or she. Speak about the patient as they are in the room during the time. Avoid to ignore to know the patient values and the patient preference all the time. Consider to say, to start with, to give them a warning. I wish if I had better news to you. I know that's not a good news to you. I am sorry, I'm going to tell you this. So you need to express your empathy to the patient. You need to give them a chance to elicit their preferences. So would you like your family to be around you during this time from the start? If you are speaking to a patient who have a capability, or if you are speaking to a next of kin who needs someone else to support him, would you rather I speak with your daughter or someone else regarding this situation? Some people will ask you that they want themselves to be involved in making the decision. Others they won't. So you may say that, like my mom, for example, or my family member will believe that I will make the decision on their behalf. You need to be sympathetic all the time. I know that's really upsetting. Is it okay? Can I hold your hand? It had been reported, although many colleagues advise that physical contact is good during this time, but many patient family has reported that they don't want any physical contact.
One of my pet peeves is when clinicians ask patients, how do you feel? People actually really hate being asked how they feel. And oftentimes that'll make them feel like they're seeing a psychiatrist or something. So what I recommend is that rather than asking, how do you feel, make an empathic statement. And that empathic statement will actually get the person to talk about their feelings. Or just say something like, tell me more. Or even maybe, what's on your mind? I think that works a whole lot better than directly asking somebody about their emotion.
So as simple as that, we need to prepare for the meeting, and we need to start the meeting having the agenda ready. We need to deliver the news to our family members. We need to discuss to them the prognosis, and we need to close the meeting after giving a summary and clear vision. Then I am summarizing and closing by tips and tricks. So take your time, be accurate. What you know, what you don't know, be accurate, be honest. We don't know everything. No one knows everything at the same time. If you don't know something, okay, I will double check. I will ask my senior colleague and I'll come back to you. Give them time to process the information. Make sure you answer all the questions to them. Active listening, so that's really important, and that's through your posture, through your eye contact all the time. Make sure that you have already your nursing colleagues all the time. They spend all the time in the room looking after the patient. They speak to the family. They know the family dynamics. They can tell you exactly about the family. You can have a good sense and expectation of the family members. Be accurate, organize it in the right way, and it is all non-verbal communication. It's really very important. You can say a lot through your look, through your voice. Your tone of voice should be up and down according to what you are saying, your facial expression. Unfortunately, with the mask, it doesn't really apply all the time, but still we can try all the time. Try to be clear all the time. Make sure that language is very clear, no jargons, and also try to having the word died if there is it is a possibility is there, use the D word. Start the conversation talking about a test report or imaging report, summarize the key points at the end, speak less, gives them time, brevity, gives them time to speak, watch the reaction. Are they confused? They need support. And also make sure that you have a debriefing at the end with your colleagues, speak to a senior colleague, and also make sure that you have your expressed your emotions all the time. Many families have been complained because they don't have a clear chat, a clear conversation. It is blunt. There is no hope, and also it has been said that it is inappropriate in terms of time or place. So make sure you have planned in the right way. And also it is very important, a clinician, you know, the family are looking after our attitude all the time. Don't let your euphemism to when you are blowing a bad news to lead to ambiguity. So try to be specified as much as you can. And also physical touch when it is appropriate. When it is not appropriate, avoid it, of course. So in summary, the expert, what they do, they prepare their meetings, they're having their agenda, they're having their goals, they introduce themselves, they introduce their agenda, they gather everyone understanding from the start, they listen actively and they don't interrupt, and also they having their empathy all the time to the family member. They also having their voice heard, make sure that everyone in the room have a chance to speak, make sure that everyone in the room understand, make sure your voice tone is changed up and down according to what you are saying, make sure you have a clear recommendation, make sure you have a reflection after the meeting. And it was always an area of improvement. So the family feedback is important. You can audit the feedback, and that's the way you can continue caring of your family patient and family members.
Is there anything more you can do?
Can you tell me a bit more about what you're thinking?
I'm an optimist. I want to clutch at every straw there is. If we haven't done everything, I got fight in me. Let's do the next thing.
You know, I want to acknowledge the fact that you've always been a fighter, and that's a quality in you I've really admired. You know, I know it's really hard for you to hear that there may not be another chemo or treatment for your cancer. I wish there were, but I'm just afraid that there's nothing out there that's not going to do you more harm than good.
If this is going to get me in the end, and there are no other options, let's get comfortable.
And that's the end of my presentation. And here is the reference I use. I would like to thank Dr. Ian Martin, ICU consultant in the Mater Hospital. He gave me lots of useful resources, and you can find more of useful resources here in my references. Thank you so much for watching and listening.
Thanks a million, Amr, for your great presentation. As I mentioned, we usually like your presentations, one of the interesting one. We have just some questions regarding your presentation. So the first question is that how we deal with breaking bad news, you know, if the patient is going for organ harvesting. So I mean, how you will address the parents or how you will address the relatives, just in case if there is any chance for organ donor or organ harvesting for those patients.
So as you know, Mohammed, organ donation is either after brain death or after circulatory death. So first of all, the main problem with organ donation discussion, it has been done in many situations before the right time. So first of all, we give dedicated good care to our patient. When our patient is declared dead, we need to give the family time to absorb that they dead, their brain dead or circulatory, their heart dead. And then we start the chat about the organ donation. So we need to have the right timing. That's very important. The organ donation team, the organ donation nurse should be involved. If it is brain dead, it could be well organized in regarding the time, because we have a brain stem testing, we have a chat with the family, we maintain their patient, and then we discuss with the family the possibility either organ donation or palliative care, palliative extubation. But regarding circulatory deaths, I have attended one case before, And it is very clear to us that this patient is going to die after extubation, we have a chat to the family. We give them time. The most important, gives them time to absorb what you are saying to them. Make to them very clearly it is a medical decision. They need to just understand and to express the values and the preference of their loved one. And then it is time is the key. And then if they said yes, they are willing, they donate the blood, they said it already in the driving license, they mentioned they want to donate, then have a discussion about organ donation. I found in many cultures, some people are scared that organ donation will make the body disfigure the body. Make it clear to them, it is a big incision in the body. They will take the organs which could be taken, but there is a chance that the team can come and say, okay, we can't take the heart, we can't take the lung. And also they have the body closed in the right way, so they can take the body back and they can look to the body. Also, the family suspicious that they can retain some of the organs and not having donated. And that's not the case. So we need to have all the information, all the details, and discuss it. It is in a timely fashion, gives them time, have everyone else on board. You know, organ donation team are excellent and they have a huge experience in this field.
Okay, thanks, Amr. The next question is, if you have, one of the patient relative or the next kin is one of those people who are difficult to manage, how you will try to address or or you are going to inform him about the bad news, especially if you got a warning from the nurses or from other doctors that this patient or this patient's relatives, is difficult to manage.
Yeah, that's really a very good question. It is all the time we care about our patients. So it is a patient-centered care. So all the conversation is about our patient. So we focus on our patient. It's a patient-centered conversation. This is number one. Number two, you try to optimize what you are telling to them, focus on the facts, focus on the problem, give them a clear fact all the time, having other colleagues to support you, having a support from social worker, with them follow up, have another chat with them in another time. But sometimes that's the only next of kin, and you can't have any other one. So you try to do your breaking bad news in the best way, less harmful way, less conflicting. Don't argue, don't conflict, don't confront. Agree with what you are saying. You are speaking from medical point of view, and they are speaking from different view.
Okay, thanks, Amr, for your nice presentation. Thanks again.